We are live.
Welcome again today to this webinar. And today we are going to be talking about again a very important topic. And that topic is advanced cataract solutions. We have with us a galaxy of speakers, and we have Dr. Saurabh Chaudhary, who's the Chief Executive Officer and Medical Director of Eye Care Hospital, Noida. He's going to be talking on what next in phacoemulsification. Dr. Nishant Patel, who's from Nishant Eye Hospital, Anand, Gujarat, and he's going to be talking on my take on new generation presbyopia correcting intraocular lenses. Dr. Gopal Raju, who's the Managing Director of Vishaka Eye Hospital, and again, he's going to be talking about a very exciting technology that is 3D visualization in cataract procedures. And Mr. Saurav Das, Senior Manager Practice Development Alcon. And he will be telling you in the end about the simple ways to integrate elective procedures in your practice. So, with this introduction, I would request the first speaker, Dr. Nishant Patel from Nishant Eye Hospital, Anand, Gujarat, to give his talk on uh, to give his talk on presbyopia correcting lenses. Just a brief introduction about Dr. Nishant Patel. He's done his MBBS he's done his MBBS in 1999, and he's a gold medalist. He's done his DNB from Agarwal Eye Hospital, and he's been fortunate to be trained both by Dr. Amar Agarwal and Dr. S. Natarajan. He's done his fellowship in retina and vitreous from the Aditya Eye Jyoti Hospital. Apart from this, he has several publications and chapters to his credit in various books, won a lot of awards, including the quiz competition awards. And he's well versed in all kinds of complex, not only cataract surgeries, but also the retina surgeries, the vitreoretina surgeries. And over to you, Dr. Nishant, for your talk on presbyopia correcting intraocular lenses.
Very good evening, ma'am. Good evening to one and all. At the outset, I like the All India Ophthalmic Society, Professor Namrata Sharma. They have been doing a wonderful job since last 6 months of lockdown. Greetings to my co-speakers, Dr. Gopal Raju and Dr. Saurabh Chaudhary. Uh, the topic today is my take on presbyopia correcting IOL, its optics and its clinical implications. My journey with a diffractive multifocal IOL started in 2005, and it is decade and a half, and probably this today's 20 minutes is in a nutshell of what I have experienced in last 15 years. We'll start with the basics. We all know that any kind of diffractive multifocal IOL is nothing else but trying to inculcate sequential diffractive optical steps, also known as kinoform, on a monofocal design, the actual size of the steps being just in few microns. The width of the step is what is going to determine the addition of the diffractive multifocal IOL, and the height of the step is what is going to determine the light energy distribution. So the narrower the width, the higher would be the addition, and the higher the heights, the more light would be diffracted for the near vision. One more terminology which is important to understand is apodization. This is nothing else but slow progressive decrease in the height of the steps, thereby making sure that while in scotopic and mesopic conditions, when the pupil is dilated, more light energy is distributed for distance, and this also helps in decreasing the visual dysphotopsia. So going to the primary basic bifocal IOL, which is of diffractive design, you have versions at zeroth order and first order. The zeroth order would be about 40% light, which is non-deviated, and it is basically dedicated for distance vision. The 48% remaining light for the first order is deviated for the near vision. What is more important is 20% of the light is lost. This is what we are concentrating when we are going to the trifocal IOL. So important because this is the light which is going to cause visual disturbance. In 2005, when we started, it was a high-end restore. Then it came down to the low-end restore, +3. Excellent IOLs for distance and near vision. However, there was a compromised intermediate vision, which came to fore with an era of digitalization, with the need of working on your iPad, your Kindle, your computer, as well as driving with navigation on. The need of intermediate vision increased. Industry answered, and then you had low-end multifocals like the Alcon Active Focus and the path-breaking technology, which is the extended depth of focus IOL. This is nothing else but instead of a point focus of light, the range of vision is increased and so is the depth of focus. So right from intermediate vision till near distance, the whole depth of focus is increased. However, they gave better contrast than traditional bifocals, excellent intermediate vision, less nighttime photic phenomenon, but they are still present. The catch here was that the near vision was a bit compromised and patient needed +1 to 1.5 diopter aids while they were trying to read up close. So we had either one option giving good intermediate vision or another option giving good near vision. We tried to do our best by doing blended vision where we combined a high-end and a low-end multifocal. Or what we did was we implanted EDOF in one eye and a conventional bifocal lens in the another eye, or a bilateral EDOF with a micro monovision. In all these conditions, if you look at monocular vision, there was a gap either in the near vision or intermediate vision, which was still persisting. So people had to combine the two lenses to give a very good range of vision, but patients needed best of both old and new. They wanted to do their professional work as well as their recreational work and also follow their hobbies, and all of them without the need of glasses if possible. So they say that necessity is the mother of all new discoveries, and that's what happened in 2010. PZIOL came out with fine vision in 2010. Incidentally, it is the same year with Apple when Apple came out with its first iPad. So a watershed zone. 2012 was when Carl Zeiss came out with its AT-LISA platform. These are the first generation trifocal IOLs. They worked on the principle of sequential diffractive optics, where if the first focal point was at 40 centimeter, the second would be exactly double to that, which is at 80 centimeter. Now, this is because of the restraints of physics, where we cannot meddle with the focal length of the IOL in case of a sequential diffractive optic. Fine vision was a hydrophilic IOL. They have now come out with a hydrophobic IOL where the light energy distribution is 49% for distance, 18 for intermediate, and the remaining for near. AT-LISA is again a very good lens, but a plate haptic lens. Again, a hydrophilic design where the light energy distribution is 50, 20, and 30. Now, to me, hydrophilic material has its own limitation as far as the biocompatibility is concerned, and so has the plate haptic design, as well as the rate of posterior capsular opacification. So we were doing wonderfully well with the patients with this IOL, but something was missing. That wow factor was missing, and that is what we were looking at. In last 6 months, probably this has come to fore. Everybody in their OPD are seeing school children and even younger adults with computer vision syndromes and dry eye. And multiple studies have shown that the ideal distance to work at intermediate vision is at 60 centimeter rather than the 80 centimeter with the traditional first generation trifocal. So there was a need of an IOL which gave very good intermediate vision at 60 centimeters. However, if we go by the principle, then the near vision would be at 30. And Alcon answered the call by introducing the Panoptics, what I call as my go-to IOL or trifocal IOL today. And we have several reasons to explain that. The design itself has been tweaked, and it is the optics itself which is scoring over the traditional trifocal IOL. The material is the same time tested, as well as the simple changes in the optics has worked wonderfully well. The diffractive zone, which has increased from a restore having 3.6 to a 4.5 millimeter. There are two additional powers for intermediate vision and near vision, which is working very well at 60 centimeter and 40 centimeter. But probably I would be contradicting my own statement because I was talking about sequential diffractive optics where an IOL would be working at 30 and 60. But they have worked out a principle of non-sequential diffractive optics, and it is a quadrifocal IOL. So what they have done is they have an IOL which has 4 focal points. So if you take the first focal point as x, the second has to be 3 by 2 times x, which is at 60 centimeter, and the third has to be 3 times the x, which is at 120 centimeter, while the fourth being for the distance. Now here the light energy distribution would be equally distributed at all 4 points. That is, you have 25% light for near, 25% for intermediate, 25% for far intermediate, and 25 centimeter for 25% for distance. But then the distance vision would be compromised. So they did something unique, what they call as an enlightened technology. What they did is they knocked off or chopped off the far intermediate one at 120 centimeter. And so what we have now is essentially a trifocal IOL with 3 focal points at 40 centimeter, 60 centimeter, and for the distance. And the light energy distribution being 50% for distance, 25% for intermediate, and 25% for near. Now, does this really work? Let us see it theoretically. The depth of focus or the defocus curve is what gives us a theoretical idea. If you look at this, it is very obvious that the vision of 20 by 25 or 20 by 20 is achieved at all distances, right from distance at 0 diopter till intermediate vision at about 1.5 to 2 diopter, and for near vision. So this is something wonderful, which is evident by the defocus curve. If you look at the Indian population, the average height is about 5 feet 5 inches. Now, if you look at the arm span of these people, it is going to be maximum around 60 to 65 inches and centimeter. And this is the ideal place where people like to work. It is not only computer. When you are trying to apply a makeup by seeing in the mirror, or while you are shaving, while you are trying to read labels when you are in a supermarket, while you are trying to drive, when you are trying to see your dashboard or your navigation system, all this is where this IOL scores absolutely wonderfully. So again, highlighting the defocus curve, if you compare with the other trifocals, there are no peaks and troughs. It is a very nice plateau which is maintained right from the distance to the intermediate to the near vision, which is wonderful, and that is what we wanted. This is something again unique. 88% of the total incident light at 3 millimeter pupil size is utilized. Now we talked about 20% light being wasted in case of a traditional bifocal. It has come down by about 7 to 8%. And essentially, this is what is contributing to less than what we expected about the visual disturbances or dysphotopsia. Frankly speaking, when the company came to us with the IOL, they said that this is a non-apodized optics. Plus, there are increase in the number of rings. So we had apprehension that there is no way this IOL is going to work as far as dysphotopsia is concerned, but they have done wonderfully well. They have increased the diffractive size, area of the diffractive rings, and more importantly, about 88% of the incident light is utilized. So it is only the 12% of the remaining light which is causing this dysphotopsia. And especially the halopropenicity is compared to a bifocal or a restore IOL. You can see with other IOLs also. So trifocal IOLs are not that bad as far as the visual dysphotopsias are concerned, and Panoptics is scoring really high on this also. Moreover, because of the increase in the diffractive area, it has become less pupil dependent. And this also provides great contrast sensitivity as compared to a bifocal IOL, and it is not the loss of contrast is not that clinically significant when you compare to a monofocal IOL. This is both in photopic and scotopic conditions and without glare. So this is again important, especially with the active lifestyle today's people are living and trying to drive in mesopic and scotopic conditions. This is something which is again helping. I had my own shortcomings as far as restore is concerned when we were trying to make people read, especially in mesopic light, Because suppose you are trying to go to a restaurant and trying to read a menu. Now in those mesopic, right, reading up close was difficult, but here that problem also has been solved beyond an extent. So you have a diffractive area of 4.6 millimeters. So even in mesopic condition, when the pupil dilates till 4.6 millimeter, the near vision would be absolutely wonderful. And then in really dark conditions, when you are driving at night, when your pupil would be about 5 millimeter or more, the peripheral refractive part comes into picture, and that gives very good distance vision. So kind of pupil dependence, but pupil independence, or you can say it is tailor made for the size of the pupil and the visual requirement. So this is again what is important. These are FTA data of the daily studies, and a questionnaire was prepared by the National Eye Institute. And depending upon the difficulty, various activities were graded, and on most of them, the IOL scored absolutely wonderfully. This is again important. The central bullseye has increased from about 0.8 or 0.9 to 1.16. Now, this has allowed us to implant this IOL into people with higher angle alpha and kappa as compared to a traditional bifocal. So again, the red flagging depending upon the angle alpha and kappa has gone down, and the number of patients whom we can implant this IOL has increased. The primary concern with all type of diffractive IOL is unsatisfied patients after surgery. Now, if you look at those unsatisfied patients, 1/3 of them are due to residual refractive error, and astigmatism is one of the major contributors. And we all know that astigmatism correction is now a gold standard as far as refractive cataract surgery is concerned. So this is the best platform for toric IOL because it is on the time-tested Acrisov platform. It is a class-leading rotational stability. So when you look at the visual performance of this IOL, because of the rotational stability, we are able to now correct people with astigmatism on a higher side with the toric IOL. Now, when you combine all these features and compare with what you have, I have no doubt in my mind to say that this is the next generation trifocal IOL. And if I have to close my eye and pick up one IOL for my patients, provided the eye is clinically suitable for a trifocal IOL, this would be the IOL. This is my experience. It is about more than 200 plus cases. And if I have to put it in a single sentence, this is what I will say. If I do my job well, IOL delivers what the patient wants. And now because we don't worry about micromonovision or a blended vision where we have to tell to the patient that your one eye would be seeing this better, the other eye would be seeing this better, and the patient would stop comparing. There is less of chair time and more patient satisfaction, and that translates into the conviction in which I am able to talk to my patient. My counselor is able to talk to the patient, which again will make sure that the patient is able to understand the technology and its limitation and take it in its stride. We drive home the message. This is a slight compromise for a huge lifetime convenience, which is important. We tested this IOL in a very critically demanding patient. He was a 49-year-old male who was working as a deputy manager in Qatar. The height of the gentleman was about 5 feet 6 inches, a civil engineer. He was supervising the development of an upcoming football World Cup, as we all know. He works on computer for about 4 to 5 hours, reads books, newspapers, desk work, also carries a Kindle when he travels. He drives to job day, less at night, but still sometimes has to drive. Recreation is playing golf and is a music lover. He was so motivated to not to wear spectacles that he had undergone LASIK surgery in 1998. So this was a post-refractive patient. We made him understand the pros and cons of implanting a multifocal IOL, about the nighttime photic phenomenon, and a need of bioptics also. This is his pre-op evaluation. This is the IOL master. This is the same on a SWEP source OCT. This is the online calculation done for both eyes. This is the true measurement by the anterior and posterior corneal power, and this is the online calculation with the Von Cuff method. And these are his pre-op data. The K readings, the lens thickness, ACD, white to white, anterior corneal power, posterior corneal power, total power, endothelial count, and QQ value. The patient underwent flex surgery, and this is the video of the same. I had attended a seminar on the same similar topic where the leading eye surgeons of India, headed by Dr. Abhay Vasavda, had given their data about the Panoptix IOL, and it was encouraging. I had also heard Dr. Jeevan Titial, the head at AIMS, talk about his experience with the Panoptix IOL, and he had talked vastly about the stereo acuity as well as the mesopic and scotopic conditions also. And these data are really encouraging. There are multiple other studies online. The Cochrane study, where they have compared this IOL with the other uh, uh, first generation trifocal IOL, and most of the data suggests that with the advent of Pen-Toric, this is one IOL which will work wonderfully well, especially in Indian population with a slightly short stature. So for me, this is something which is working very well. I'll just run through the video fast. This is the IUL. And these we implanted plus 16 and plus 17 diopter respectively in both eyes. This is the post-op result, and this is the post-op slit lamp photograph. This was intraoperative, and this is the post-operative. This is the magic of flex. If you see a very well centered rexis around a very well centered the optic with a 360-degree cover of the optic. So thank you for your kind attention and patient hearing. I would request Professor Namrata Sharma, if she can, to share her experience of the study at AIMS. Probably we can start the discussion with that, if that is fine to her.
Thank you, Dr. Nishant. I think you covered everything so well. Multifocal intraocular lens, is not a easy topic to understand, but the whole presentation went in such a nice flow. It was like telling a story and telling it, very well. So I think we can take some questions before we proceed. We did do a study of stereo acuity to stereo acuity not only for panoptics but also for EDOF lenses like symphony intraocular lenses. And we found that when you compare it with the other multifocal lenses, the stereo acuity was far better. Now, one question that everybody asks is that uh, what practice of your IOLs is multifocal IOLs? So if
Uh,
each one
Ma'am,
of us,
yeah,
so what percentage of your patients are multifocal intraocular lenses, and do you actively counsel them, or do they ask for it only then you offer?
no, ma'am. I think we started inculcating the idea of making the patient aware about the options right from the place where the patient waits in our OPD. So there are certain posters which are kept about flex as well IUL's options, where the patient is able to live their life being less dependent upon glasses after cataract surgery. There are no specific names put on, but it is the idea that this is possible. So once the patient goes for pre-op evaluation, the flow is in such a way that from the optician or the ophthalmic assistant, the patient, if they diagnose the patient of having cataract, they'll go first to the pre-operative area where the virgin eye is undergoing a whole gamut of pre-operative evaluation. And again, there also, when they are sitting, they are surrounded by certain audio visuals where they know that this is something which is possible. Then I review the data and the patient goes to the counselor. So when the patient goes to the counselor, they are given both the options. Like you, so we now start talking about, you have an IUL which is monofocal, you have an IUL which is toric, and you have an IUL which is multifocal or bifocal and trifocal with EDOF. So we give all the three options. There are some PowerPoint presentations with them where they show the advantages, disadvantages, as well as the nighttime photic phenomenon pictures are also shown. Now, what this has done is the grudges of the patients certainly remains at the back of their mind that they are seeing rings, but they are mellowed down because they understand. And this is something I picked up from Dr. Naren Shetty when I was at Narayan Netralaya. He told me that when a patient talks about diffractive rings, I tell them that the basic fact that they are seeing rings is making sure that the IOL is working. So they will see the rings only when the IOL works. So this is something which is helping me to talk across to the patient. As far as the second question was concerned, when you asked about the percentage of my practice, it is about 15 to 20% of my total practice. Obviously, the patient undergoes ocular surface evaluation and the vitreoretinal interface evaluation, the OCT as well as the dry eye management, and we have an eye tracy, and now with the newer generation optical biometer, angle alpha and angle kappa are evaluated, and their red flagging is done, and suitable patient undergoes the trifocal IOL surgery.
So I think that was a very nice way you put your entire practice. And I think Dr. Saurabh, your talk is already over before it even got started, because very nicely Nishant has explained how patients have to be motivated. And that was a great tip, that if you see a ring, actually that means the mechanism of the lens is working, and that is why that ring is there. And apart from that, 15 to 20% is the multifocal practice. I think we need to be aware about that. Having said this, there are subtle clues which are there in your clinic or in your hospital or in your nursing home, so that the patient becomes aware. But there are patients who already Google and they come, they already know that they need a multifocal or they don't need a multifocal, and they will Google everything and come. So that was it. I think we'll go to the next talk and we'll take some more questions, Nishant, on the IOL. So do stay with us. The
Yeah,
next
thank you.
next speaker is Dr. Saurabh Chaudhary. He's a very good friend of ours and also my neighbor. So I know him very well. And he is the CEO of Eye Care Hospital, Noida. He's passed his MBBS from Stanley Medical College, and then subsequently did his fellowship from Shankar Netralaya. And he's done numerous presentations at ESCRS, ASCRS, and as well as AIOS, and has written several book chapters and has several publications to his credit. So he's going to be talking about a technology which is next in FACO. So what next in FACO technology? Dr. Saurabh Chaudhary. Saurabh, you have to unmute yourself. I think you are muted.
Right. Sorry. Thank you, Dr. Namrata, for the introduction, and thanks a lot for. It's always a pleasure to be on the AIOS platform, sharing the dais with you. I'll also want to thank the Alcon for inviting me over. It's an Alcon sponsored session, and hence I'll be mostly talking about the Alcon specific products, and so. We've had the Alcon platform for a very long time, and they asked me to talk about what's the newest things, what are available, and how it is moving forward. So here I am, and let's start. Right. So the Centurion vision system, or the FACO machine, has been there for some time, and it was a drastic change in what we used to work with our Infinity systems and the other systems which we had. And suddenly, with the onset of this, there was a paradigm shift to what we could do in our cases, and that's how our journey started with. The active fluidics was something which was very different from the initial Infinity and the Laureate systems. The active fluidic changed the whole scenario and how we work with our FACOs. We then had the balanced energy with these systems, and I'll talk a little about this. The tips and the sleeves, which are the Intrepid platform on the Alcon systems, and my initial evaluation of the newer tips which are there. So my talk is basically on the evaluation of the new tips which are available. So the active fluidics, as we all know, and we've learned about it over the past 6 years now, that that's an irrigation system of active fluidics, which was first introduced by Alcon. It responds more quickly to the changes in the IOP, and instead of the BSS bag, which in a traditional machine is hanging on a pole, and it's the gravity which drives the fluid in. Here, there are pressure plates which compress and decompress as needed to maintain the surgeon-selected targeted IOP. So on the machine, you can actually control how much IOP you want, and if it is a high myop, you'll want to keep it a lot lower so that there's less pain. And besides that, there are a lot of other advantages. In fact, we've gone down to IOPs of 20 as well, which is almost equal to what a normal IOP of the eye is. Basically, why these platforms came on was because of the balance energy, and the balance energy was ultimately the torsional phaco systems changed the whole scene altogether. Now, what is a torsional system is that instead of the longitudinal, which is the traditional system, the tip here does not move to and fro, but it moved from side to side, and hence a Kelman tip or a bent tip was very essential, and this was introduced in 2006. It had a few problems, and this was the intelligent phaco or the shots of longitudinal phaco were incorporated in 2009, and after the intelligent phaco came in, for the past 11 years, our whole understanding and our whole way what we operate has changed. The balance energy technology with the balance tip was introduced in 2013 along with this the Centurion machine, and how we work and the cases we took up for our phacos were a lot different, and we could take up a lot of other cases which were not amicable to phaco earlier. Now, there is a great software which balances the energy there. It accommodates the surgeon settings for aspiration and vacuum, as well as the OSL parameters. It increases the cataract material removal efficiency and achieving the procedural balance. So in fact, what this slide is trying to show is that in foot position 2 and foot position 3, you can actually change the vacuum what you set, and these are the parameters what we can actually set up here, and you can actually change them, and that's how versatile the machine is. This is the balance tip which I was going to talk about. So it's a novel tip designed to reduce the stress on the eye. It is maximizing the torsional tip movement and minimizing the tip movement at the incision. So that's the tip, and that if that's in the eye, it rotates at the hub there, and in front it just gives a movement, which is the maximum movement happens here with the minimal movement there. It's just a torsional movement. So that's what it is called. So the energy dissipated is 31% than the distal maintaining wound integrity. There have been a plethora of studies on this, and the heat production in the longitudinal versus torsional, and after the balanced phacoemulsification tip has come in. So the Kelman tip, which was the earlier tip, had a maximum amplitude of 130 micrometers, which has increased to a 192 with the balanced tip. The new sleeves have helped quite a bit, and these new ultra sleeves do have some finned structure inside where the flow has increased along with the active fluidics. So the way we are working in the eyes and the cases we are taking up has totally changed. So my experience is significantly been better with the thermal profile and better wound integrity. My whole phaco power has come down when using, as compared to the Kelman tip, about 30%. My surgically induced astigmatism has reduced from 0.34 to 0.25, and the chances of clogging of the tip has especially come down with the balanced tip. It becomes a faster procedure with lesser use of BSS and hence clearer corneas. There is a more stable chamber, what we have seen, and we are able to customize the IOP and use higher vacuum and higher AFR settings. Now, with this shift in the technology, what is the new? Well, like Centurion has been there for the past 7 years now. What's actually new right now is the new Interpret hybrid tip. And what is this hybrid tip? It is a rounded polymer edge designed to reduce the risk of capsular tears. So whatever safety we had, we're increasing the safety by providing this silicon, sorry, not silicon, the polymer sort of an edge to the tip. The cutting performance is almost equal to a metallic tip. It does, so I've tried it on harder cataracts as well, but nuclear sclerosis grade 3+ is very easily done. The fluidic performance and the configuration is exactly similar to the balance tip, so hence there is no change. So this is the tip here, and we can actually see that they've added this polymer here, which blunts the metallic edge here. So this is one of my first cases which I did perform here. So I'm just trying to show the tip here. It is nothing different from what the tip was, except that the polymer, and you can actually see the metallic tip inside there. And I am going to perform a surgery, and this is one of my first few cases, and I'm performing my direct chop here, and this is in real time, and I am going ahead and chopping the case. And you can see the fallibility is very good. The chamber stability is as it was with the balance tip, and we're very sure about the chamber motility with the Centurion vision system. And as you can see, the fallibility, and it wasn't a very hard case, and we could actually go ahead and just finish off the case. And that's the beauty of this tip, that because of the safety parameters, I could actually remove all of the cortex without even going in with the IA tip, and there's something which was stuck behind. So I'm actually going onto the PC and scraping off the cortical fibers from there. So that's the safety of the tip which I was trying to illustrate, and you just put in the lens thereafter. So that's what I was trying to say, that it becomes a lot safer, and especially in a case like this, which was a case very high myope. So I've done the Rexis, I've done the hydro, I go in with the polymer tip, the new hybrid tip. I'm going to embed and start chopping. So that's the chop which comes in. It's a softer cataract again. I rotate it around, hold it, and start chopping again. So what the problem with the balance tip at times was that in softer cataracts, it used to cheese wire. It used to just go through the cataract. And here, the whole problems which some surgeons used to face with the balance tip just goes away. So you just get it in, and you can check the fallibility. It just comes in very easily, and you're right in the center. And using minimal power, we're able to emulsify this. And this is a bigger chunk which I've taken, as this was a softer cataract, and it's a high myope. And I've kept the IOP as about 22 here. And using minimal power, still being a high myope, we vary about the fluctuations, but the active fluidics work very well here. And I'm able to remove the cortex here. And you can see there's no, the stability of the anterior chamber. Again, in this high myope, I'm just scraping off the fibers from the PC. These are some fibers there, which I'm just going to scrape off, and I've put the lens in thereafter. This is a hypermetrope, and I've just done the hydro here, and I am going ahead and trying to do a sculpt. I've sculpted it a little bit. Going ahead, chopping it into smaller pieces. This was a shallow AC. I did use a little bit of viscoat here. And as we can see, I am able to remove there is no compromise in what we had with our Centurion machine by using this hybrid tip. And it's going to change the whole game altogether, because I've just used it in 3 of my OTs, but I have in quite a few of my cases not used the IA at all. And I've just been able to finish off the whole case without introducing the IA. Basically, I was trying to demonstrate that the safety of the tip and the chamber maintenance, as well as the PC which stays back all the time. So here we go again, and here you can see that I'm going, in fact, behind the iris as well to pick up the cortex. That's the cortex which is being pulled out, and I'm not using a IA tip here. I think in this case I had to, but this being a high myope, I'm using one of the expand series of the Alcon lenses here. Now this is a small pupil with sticky cortex, and as you can see, it was very small. So here we're going to embed it, and it was slightly on the harder side, and it's one of the diabetic cataracts which is slightly sticky. So that's my initial chop, which I've done here, and that's the second chop. I have to do a multi-level chop here because it's a sticky diabetic cataract. So this is the multi-level chop what I'm doing. And as as it's a small pupil, so here I was just trying to show that I have actually caught hold of the iris also. So I'll just try to go back slightly, and let's see here as I am going ahead, I am chopping here, and if you see here, I have, that's the next chop here, and if you see here, while doing this maneuver. So that's the chop which is coming through. I'm now removing this cortex, and I back slightly. I just wanted to show that I've actually held the iris edge there, and in spite of holding the iris edge, it's such a great tip that the pupil hasn't come down. There's no iris dispersion, and I've been able to manage this case without the use of any rings or hooks, in spite of my doing a maneuver where I actually held the iris. I'll go on to another case here. Sorry, this is my last case here, which I want to show. I'm going in using the same tip. That's my initial chop. Gone in, the chop going through and through. Chopping it at various levels. This is the cortical cataract, which is slightly soft. Just rotating it around. And the efficacy is as good as a balanced tip. I've just forwarded it a bit. And now, as you can see, I'm going in and I'm just going to remove all the cortex with this. I have actually held the PC a couple of times with this tip as well, inadvertently, and there was no PC tear. And in the last case, as I was trying to show, that I actually inadvertently also caught hold of the iris without any issues. So it's a great tip, and it increases the safety of the whole, and the whole ball game changes because the safety parameters have changed altogether. So I found that it cuts very well and does not have any negative effect on my efficacy. It is much less likely to break or damage the capsular bag, the capsular, the PC, which any other metal tip which have a slight burr or scratch would do. And this cannot happen with the hybrid tip. So that's what I would say, that it's increased the whole ball game. It's soft and kind to whatever tissue it engages. The hybrid tip can remove segments of the nucleus and make grooves or divide and conquer as well. And I've done it for grade 3 as well as a grade 3, almost +4 cataracts. I have not evaluated in very hard cataracts, but I have done it in an intumescent cataract as well. And the efficacy, there is no compromise on the efficacy. The only case where you may lose some efficacy is low vacuum sculpting, if you want to do that in mature or brunescent cataracts, but it still can perform well once the cataract is fragmented. So it's the subtle edge in handling very soft grade cataracts. That's how it helps you out, and that's what my advantage is. That whatever problems I used to face with this softer cataracts, with the balance tip, I don't face them anymore. It can help make it work near the capsule for removing the epinucleus, and that's what I tried to show in all my videos. And it can be a justification to be able to perform in the bag implant, in the black phacoemulsification, to cut down this the cumulative dissipated energy and the fluidics, the BSS consumption, leading to clearer corneas. Thank you. Thank you.
Thank you, Dr. Saurabh, for your lovely presentation. And there are some questions which are there from the previous presentation also. I think we like to take them because that would, at least answer the audience questions and keep them engaged. So the question is that in case there is a, Nishant, this is a question for you. In case you have to advise a fellow ophthalmologist, would you advise EDOF lens, or would you advise a quadrifocal lens like PanOptix that you talked about, or would you advise a monofocal lens?
Thank you, ma'am. This is a wonderful question. Probably this would be easiest patient to advise because the ophthalmologist himself knows what he is up to and what are his visual demands. Uh, as far as the optical quality is concerned, I don't think when you are operating from a microscope, it is going to get compromised too much if you are trying to focus well. The only limitation of an EDOF IOL is because it's not a single point focus, the sharpness of vision is not there. When you compare EDOF to a trifocal IOL or say panoptics, the contrast is pretty, or the loss of contrast is pretty much same. So taking out the surgical part and the remaining lifestyle would be much more easier with a trifocal IOL. As far as the loss of contrast is concerned, I don't think either you go for a monofocal IOL or you go for a presbyopia correcting IOL. You don't need to choose from EDOF or a trifocal IOL because both of them lead to a loss of contrast.
Okay, so I think it is little bit of contrast losses there with all kind of lenses where focality is coming into being, but if but otherwise they do well for all other lifestyle activities. Having said this, I have implanted EDOF, in surgeon and also in gynecologist, as well as trifocal in doctors, but we've not had any problems. I mean, not come across any problems that they would have faced. Then, is there any age limit for the panoptics lenses? Can we use them in the age group of 80 years, or can we use them in the age group of 11 years? So, I would like to know from the panelists, Dr. Gopal Raju is there, from each one of you, that what is the youngest age that you would consider panoptics for? Dr. Gopal Raju?
Yeah, I think I prefer to use. Can you hear me, Namrata?
Yes, yes, sir.
Yeah, yeah. I prefer to use panoptic lenses in the senile group only. That means above 35 years of age. In young age, if it is a bilateral, then I would prefer to use above 20 years. And below 20 years, still we don't know the long-term effects, so I will avoid. The reason behind avoiding the unilateral group in the age group between 20 and 45 is, so there will be a comparison with the other normal eye. So the contrast will be less in the multifocal eye. So invariably the acceptance will be less and the patient may not be happy with that. So that is the reason why I avoid a lens, multifocal lens in the unilateral eye between the 20 to 45 age group. Above 45, yes, definitely we'll go ahead with the multifocal lens.
Okay, and Dr. G.S. Dhami sir is asking a question, I think, which is very pertinent, and that is, what would be your threshold for astigmatism when you are giving a trifocal lens? Saurabh, would you want to answer that, and then we can take Dr. Nishant's comments?
Right. I wouldn't want to put it. So I'll use a panoptics toric in case it is required. In any case above minus 0.75 diopters, if I'm putting a trifocal or a quadrifocal lens like the panoptics. But if let's say the patient has a 0.75, I would still want to put a simple panoptics. So that's what my threshold is.
Nishant?
Ma'am, in pediatric age group, definitely no. We would like to allow the eye to mature enough to come to the adulthood dimensions before we go for any kind of presbyopia correcting IOL. As rightly pointed out, I have implanted few in younger patients between 20 to 40 years age group.
I think there is a connection problem there. And Dr.
So,
Gopal Raju, would you like to talk about the astigmatism? What would be your threshold for doing a toric, a multifocal, which is toric?
Yeah, earlier we don't have the option of the toric multifocal IOLs. In such times, such situations, our threshold was up to 0.5 in bifocals and earlier generation multifocals. But in the EDOF and then the multifocal trifocal IOLs, we can stretch up to 0.5 to 0.75. Beyond 0.75, now we have the availability of the toric multifocals, so we'll go ahead with the toric multifocals if the astigmatism is more than the 0.75.
I think we are all on the same page that our threshold becomes, lower. Nishant, you wanted to comment on that astigmatism part. We lost your connection in between.
Okay, ma'am. For astigmatism, obviously, the tolerance value which the trifocal is showing is a residual astigmatism of less than 0.6 is tolerable. More than 0.6 is not tolerable. So any kind of against the rule astigmatism of 0.6 or higher, and with the rule astigmatism of 0.8 or higher, we would be going for a toric trifocal IOL implantation.
So I think our threshold will be lower as compared to, when you do a monofocal toric. The threshold for
Obviously.
a multifocal toric would definitely be much lower because there it really benefits a lot. Then there's another question.
Namrata,
Yes.
Namrata, we can if you have the case added to the lensex, then we can add the arcuate cuts, and then you can go up to 0.75 to zero point 0.8 or zero point 0.9, and then get away with the simple multifocal, and then with the additional arcuate cuts with the lensex.
Okay. So I think that is the advantage of Lensex. And if you're
Yes,
doing a case with a femtosecond, that you would have a keratotomy option there also. Uh,
yes.
another question is again for Nishant for you, and that is that after implanting, Dr. Upendra Singh is asking, after implanting Panoptix trifocal after 2 weeks, patient is complaining of some cloudiness in the distance vision. So what do you, if it comes like that, how will you counsel the patient, and what do you think would be the possibilities?
It is a very good question, but it is difficult to exactly point out without seeing the details of the patient. Whatever data or whatever my experience is, first of all, we like to allow the refractions to stabilize for at least about a month, month and a half before we comment about it. But we'll definitely keep an eye on the distance vision the patient is complaining. So the two surfaces, the ocular surface as well as the vitreoretinal interface, can be a culprit when the patient is complaining of distance vision. So we might repeat an OCT if at all we are looking for a cystoid macular edema. Rest of it, probably any astute surgeon would do a complete examination to rule out any inflammation or any kind of uveitis. Uh, Other than this, as of now, I haven't had an experience where the patient complains of distance vision of a slightly lesser quality after 15 days of a trifocal IOL.
There is another question, and it's very interesting that if there is a case of pterygium, if there's a case of pterygium with cataract, would you counsel such a patient for a trifocal lens?
Again, a very pertinent or clinically relevant question. As a rule, when we are trying to implant a presbyopia correcting IOL, we try to make sure that we remove the pterygium first, allow the cornea to become pristine, and then evaluate the patient as the keratometry values are concerned, allow it to stabilize, and then go for a cataract IOL surgery. Whether the pterygium is clinically significant or not, because that is going to contribute to the ocular surface abnormalities later on, and if that gets inflamed, again the visual quality will be compromised.
So I think that message is very clear, Nishant, from what you said, that if you are having a pterygium and if howsoever insignificant it is, and you are planning a multifocal intraocular lens or planning a trifocal or a panoptics lens, then it is important that you do the pterygium first, see how the astigmatism is. Of course, if there's an irregular astigmatism, then it's a no-no. But if it is not, then maybe you can take a call on that at a later date. So there are questions relating to the machines, and that's for you, Saurabh. Who makes the balance tips and where are they available? So I think
So the balance tips are only available on the Infinity or the so the platforms of Alcon machine. So Alcon makes them, and they're only available on their platforms. So you can actually order from Alcon and you can get them, but you have to have the machine. You can't put it on any other uh, handpiece.
there is another question which I think I will take in the end. It's a slightly uncomfortable question we can take after all the talks are over. But another question for you, Saurabh, is that if that soft plastic drops in the chamber while working, has it ever happened, or is there a possibility of it? What
So
I think about it.
I have actually used that tip only in 3 of my OTs, and I have uh, put it through the ETO. And in the third OT, I thought the efficacy had slightly gone down. And after my third OT, I decided to actually examine the tip, and I broke the tip. In fact, I was trying to break it. So it's not very easy to break it, and I don't think it is going to break. So it's almost like it's a polymer tip. It's not soft. It is polymer, but it's not soft. But it has rounded edges. So and as I said, that I have caught hold of the PC a couple of times, and I have caught hold of the IRS once, and it has not. So these were my initial evaluation, and I've just done it for 3 of my OTs. But as I said, that after my third OT, I tried to break it, and it didn't break. But it hasn't come off, or it hasn't come off in the AC. Definitely not.
So basically, I think active fluidics really helps you in that manner that if you get caught in a situation, which is difficult, it bails you out, and it is more forgiving as compared to the other systems. So I think with this, we will move on to our next talk, and the next talk is by Dr. Gopal Raju. Uh, do I have to share? Should I share the presentation, or
Yeah,
is
yes, Namrata, please share. You have to move the slides when I'm saying next slide.
So Dr. Gopal Raju again needs no introduction. He's been my senior and he's been an RPC alumnus. He's been extremely helpful to me personally when I was a junior resident when I entered, and now he's at Vishakhapatnam, and he is the founder of the Vishakha Eye Hospital there, and a very prolific surgeon. Can you see the this thing? Should I decrease it?
Yeah, please decrease slightly. Yeah, right. Now it's perfect. Yeah.
And I think he's going to be talking about Ingenuity, the head up 3D image guided surgery. So the thing is that these setups like Femto is here to stay, like newer surgeries like Smile, etc. here to say. Likewise, all these things are here to stay, and they do have an added advantage. So Dr. Gopal Raju, please.
Yeah, thank you, Namrata. I thank AIOS and also the Alcon from bringing this technology, and also for giving me this opportunity to share my experience with the Ingenuity or the 3D image guided surgery. Next slide, please. I don't have any financial interest. The next slide, please. So before going to the actual topic, if you see the evolution of the science, it has evolved from the earlier civilization to modern day civilization. It passed through some industrial revolution, then agricultural revolution, and then the IT revolution. Now, next slide, please. Now we are in the modern revolution. So if you divide the entire revolutions into first generation, that is the railroad, and then the electricity steam engine, then the second generation, then the third generation. Now we are in the fourth generation of the revolution. So that is now going to hit it with the artificial intelligence, the robotics, and whatnot. So femtosecond, we are in that mode. Like femtosecond laser is one of the starting of that, and then we this 3D Ingenuity is another added feature in that. Next slide, please. So coming to before going to the actual 3D, how it is different from the our routine surgery. If you classify the overall surgery type of surgeries, we started with the naked eye surgery, then surgery with the loop, and then the microsurgery if you use the microscope, and endoscopic surgery if you use the endoscope. And then if you see the image and then do the surgery, that is called the image guided surgery. And our 3D Ingenuity comes under the image guided surgery because we are not directly visualizing it. And if that is done by a robot, then it's called the robotic surgery. Next slide, please. So we are in the 3D image guided and the robotic. Robotic can be with the Lensex. Before going to the how it is different from our microsurgery, we should know little bit basics about the human coordination. It's called the motor response due to sensory input to the human body, because the movement of our parts in response to the sensory inputs, so it needs to be coordinated. That is called the hand. Best is the sensory to sensory coordination or the sensory to motor coordination. Coming to the sensory how heart rate or respiratory rate varies with the oxygen demand. That is the sensory to sensory coordination. And then sensory to motor, so when the high hand coordination and the gait are the best examples of the sensory to motor coordination. And our ophthalmic surgery comes under the hand eye coordination. Next slide, please. So in that hand-eye coordination, there are some hidden things. The movement of hand due to visual input. So we will be seeing the cataract, and then we will decide to touch it. Then our hand should move. So this visual input, brain processes it, and then the output is the motor command to the hand, and hand moves. So further, eye fixates on the target before the hands are used to engage in a movement. So the eyes provide a spatial information to the hands. This difference is in milliseconds. So this happens in milliseconds. Generally, it will be less than the 25 to 30 milliseconds. So any instrument which takes the image from the eye and then to the hand, so it should be within that millisecond. And this moment, once in an experienced surgeons, the moment you see, our hand will move automatically. So that is called the proprioception. Next. So automatically, when we are using the microsurgery, our hand moves within no time. So there is no question of any lag in the movement of the hand. And in an experienced surgeons, the hand moves automatically. That is, the proprioception is very active. In the microscope, there is a direct visual response and no intermediary. So we'll see through the eye, and then with the action of the movement of the signal response from the brain, the hand moves. Whereas in indirect visualization, the camera captures and then sends that signal to the monitor through two-dimensional vision. There may be some time lag depending upon the gadget. Though here the challenge is it should process it as fast as your brain and then send it to the visual input. The hand movement depends upon the completion of the saccades, short and long in ophthal. It is in milliseconds. This varies between 100 to 200 milliseconds in a normal response, and any delay beyond this affect the high hand coordination will be affected. Suppose if the image processes is coming late, next slide, please. Then our hand moves faster before the image moves. The coming to the three-dimensional imaging, and then once in the 3D imaging, a series of anatomical data is gathered by the system and the technology and processed by the computer and later showed on a 2D monitor to present the illusion of the deepness. The 3D imaging is widely used in diagnostic like software reconstruction, and 3D imaging is the treatment modality is the challenging in live processes. And the resolution main advantage is very high. You can see even the blood flowing in the conjunctival vessels. And the stereopsis, there is an extended depth. So there will be an extended depth of the anterior chamber where the play can be increased. Next slide. This is how the Ingenuity works. So it consists of the 3D camera, which is attached to any regular microscope, and then that captures the image and then send it to the processor, and the processor will then in turn will be displayed in the monitor in a 3D, and then we have to use the Polaroid glasses and then to get the effect of the three-dimensional image. Next slide. So this Ingenuity is a imaging tool. So Alcon has introduced in way back in 2017, already 3 years. But initially they have introduced for the retina. mainly to tackle this lag time. It used to be more lag time. So that's where the retina, the instrument's movement is not as fast as in the anterior segment. So they first introduced in the posterior segment, but as the newer generations and advancements in the software, they've reduced that lag time, and now it's almost within the range of the human processing system. So now that lag time issue is not at all there. So when they could overcome that lag time, so it now can be safely used for the anterior segment and the cataract. Now next slide. So this can be used in the pterygium surgery. I will play the video at the end. Next slide. In all kinds of the surgeries, even you can use it for the trabeculectomy, where everything can be visualized at a higher depth. Next slide, please. Can be used in the 3D guided imaging phaco surgery. All anterior surgery segment surgeries can be used. Next slide, please. So it gives a good resolution, it gives an extended depth, more flexibility in the instrument movement, and it is very safe. And it can be used for most of the anterior segment surgeons. And it's hardly any learning curve, and there is a less strain on the surgeon's neck. And the good part is your entire team in the surgery will start involving in the surgery in each and every step, and they will enjoy the entire process. And it is one of the best tool for the teaching. That is the main advantage. The postgraduate teaching, it's an excellent tool of displaying the all the steps of the surgery. Next slide. So this is in nutshell about the 3D Ingenuity. Kamrata, can I share my slide? Just a video I'll play.
So I think that was an excellent presentation on 3D surgeries. What companies also need to do is that we are doing 3D surgeries, but we should also be watching them like this, sitting on our laptops. Then that is the beauty of the whole thing. And I don't know when that device or that thing is going to actually come up. Yes.
Amrita, can you see the slide?
It came for a while and now I can only see my picture. I don't know why. Yes. Now it has
No?
come. Yes, it has come. You can play now.
Yeah, yeah. You can sit relaxedly. So you can see how entire OT team they can wear and then start seeing and each and every step. So neck movement and then the entire surgical process. Each and every step, it's an excellent tool for the postgraduates. And the safety is increased. The other, when introduced in 2017, it was an off-label use. Now I think it can be used for all the surgeries. There are other companies like JAIS and then the Appaswamy also. They came out with this type of the instruments. Even the posterior capsule, everything we can see very clearly. And then, yeah, that's it, Namrata. Thank you. Thank you.
Thank you so much, Dr. Gopal Raju, for that excellent presentation. And are there any questions from the panelists on this? We've had we have both the systems from the Zeiss as well as from Alcon, the 3D systems, and I think the 3D system, they were the first ones to come up with the 3D system, and it works well. It is very useful, especially for your ancillary staff who's with you, who's assisting you, the anesthetist, the nursing staff, etc. also, because they know what you are actually doing, and whenever there is a problem or a complication or whatever, they can, witness it and help you accordingly, as per step which is required. So,
Yes.
Nishant, there's one question for you which was left. Was Dr. Sirisha wants to know: is there any use of multifocal? Would you counsel a homemaker female patient for a multifocal intraocular lens?
Ma'am, why not? These are the ideal patients actually.
Okay, and
Because
yeah.
all their daily chores probably would require different range of vision, different activities, right from cooking, say separating grains to cutting vegetables. I have my known family members who are into knitting, or see, their hobbies are also certainly important, and all these are important. A homemaker would be an ideal patient for any kind of presbyopia correcting IOL, and specifically a trifocal IOL, because we are not worried too much about the nighttime photic phenomenon.
So there is another question for you, Saurabh, and that is: can this tip be used with other machines or other handpieces? Unmute yourself, please.
Sorry, yeah. So this cannot be used with other hand pieces. It has to be used with the. So I've tried using it with the Infinity platform as well. So it works on the Centurion and the Infinity platform, and I think it can be used on the Laureate platform as well. But it cannot be used for other companies because the tip will not fit on.
Dr. Gopal, yeah.
Namrata, yeah, can add. See, the main advantage of the advanced tip is, see, the Alcon machine, the movement is horizontal. That is torsional phaco. So whereas other companies, the non-traditional or the recent phaco systems the mechanism is entirely different. So even if you attach the same tick, basically it should be a Kelman, modified Kelman tip with the advanced modification. So even though they can attach this, they may not get the maximum efficiency out of that, unless you have the software similar to the Centurion with the torsional phaco. So that's the main reason.
Okay, so there's a question for you, Dr. Gopal Raju, and it is that Dr. Sarvana Bhava wants to know: what if the video monitor stops playing during your surgery?
Yeah, that is like as good as your microscope stops playing. So you can simply take out the 3D camera and you attach the regular eyepiece and then go ahead with like a normal microsurgery.
Like a normal. And Dr. Nagendra Vashisht wants to know, I think from all of us, do you check the dominance of the eye before proceeding for bilateral multifocal intraocular lens implantation, Nishant? The dominance of the eye. I think we've lost connection from him.
For implanting regular bifocal lens, sorry.
So Dr. Gopal Raju, would you want to take that?
Yeah, in monovision concept, when you are trying to correct the multifocality, then the dominance is required. And also earlier when we were using the plus 2.5 and plus 3 and 3.5 different ads mix and match category, in such situations the dominance checking is important. But whereas in the modern, when you are going bilateral, trifocal or EDOF, I don't think that is required.
Okay. All right. So then there is another question on what if the patient wants a multifocal intraocular lens and cannot afford it? So do you counsel your patients for options, which are less expensive?
Yes, definitely. There are generic IOLs. We can offer them at a economical, affordable price. And then if they are ready, we can go ahead. There's no harm.
So I have not had a great experience with the other generic multifocals. The other IOLs are great. but monofocal IOLs are great. The torics are also very good, but I haven't had the best of experiences with the generic means the IOLs which are multifocals or trifocals from the Indian brands. So I'm slightly skeptical about it.
Nishant, what would you say?
Actually, we are into implanting the Indian multifocal IOL, but as Saurabh rightly suggested, they have their certain limitations, though they are improving. What I was the slight uh, erratic refractive evaluation of the IOL is now becoming better, and over a period of time they have definitely improved, but the finesse which you get with these kinds of IOL is not as good as what it should be. So probably over a period of time you would get Indian IOLs that would be at par with the MNC IOLs like the Panoptics, or say with Johnson and Johnson or Abbott or Carl Zeiss.
So I think for us, we have the availability of only these IOLs, the ones which are imported, and so we have not, compared it with the IOLs which are Indian IOLs. But I'm sure, and I think because we talk on the platforms, we really don't have too much of comparative data, although we do speak anecdotally, and I think it will be useful to do a study to say, how these compare well with the what is the level of comparison with the Indian intraocular lenses, which are multifocal or extended depth of focus in principle. So I think with this, we come to the last talk. Dr. Saurabh Das is waiting. And I think this is the most important talk of the day. So Saurabh, can you share your screen? This is a talk which I think everybody needs to listen to, because it's going to give a lot of practical tips on how to build up your practice. And
can you see my screen? Yeah.
Yeah. So Saurabh is going to tell us about simple ways to integrate elective procedures in your practice, and he's Senior Manager Practicing Development, Alcon India Surgical Marketing. And I think that way Alcon has really taken a lead, because they have a whole system in place with counselors. They actually tell you how to develop your practice in not only in terms of multifocal intraocular lenses or otherwise, but in terms of premium surgeries and in terms of premium IOLs. So over to Saurabh for his talk.
Thank you, Dr. Namrata and AIOS for giving me the opportunity to share my views on this subject of how simple it is to integrate elective procedures in your practice. Back home, I mean, we are a team of 5 and collectively 70 years of experience in eye care. What we do in this organization is integrate any advanced technology into practice. That's basically what we do day in and day out, and trying to help practices so that this transition becomes seamless. We've been hearing, we keep hearing about different technologies, how beneficial these technologies are and how good they do clinically to all of us, to the patients. Now, it's also important for us together to learn, how to integrate this technology, how to communicate the value to these patients, such that, you can subtly and, you can seamlessly and judiciously and, rightfully actually monetize the investments that you've made. And this topic is all about that. By the way, this happens to be one of the top 3 challenges that a clinician face today. The first happened to be, how to retain and motivate your hospital staff. The second happens to be, how can you monetize on the advanced technology. And the third happens to be, how can you increase the check-in to check-out of experience of your patients. So let's talk about it. So the first and foremost thing, why is it actually important to even have an advanced technology integrated in your practice? And I've listed 5 reasons why you should be investing in advanced technology. Number one, it widens the basket of services that today's modern patients actually are looking for, their visual demands. We've termed this coin as the new generation elders. Their visual needs are different, and that's one of the reasons why you should be widening your basket. Second, this acts as a differentiating factor from your neighboring practice, and we all know this. The third happens to be, this obviously helps you bring in more revenue to your practice. And this also helps in developing, your near advances in future. For example, learning toric. We all know that there's a little learning curve when it comes to astigmatic correcting IELTS, and and if you learn it at a later stage, all the advancements are happening in the toric platform. So it's obviously important that one learns this technology. And lastly, this is absolutely the right time. In COVID times, this is the absolute time where there is a heightened awareness about safety and disposability, and that's one of the important reasons why one should consider integrating and having and investing in advanced technology in your practice. So what advanced technology are we primarily talking about? So any elective procedures, any procedure, product, or service which reduces the dependency on glasses or enhances safety, or even fastens the rehabilitation process, or just gives in a great check-in to check-out experience of the patient. Now, these are all elective services and procedures which can be charged a premium. A decent amount of appropriate premium can be charged for this. I listed some very interesting top myths, and I was just hearing to the conversation, and a couple of them just popped up. Here are the couple of myths when it comes to integrating any advanced elective procedures in a practice. These are what practices generally think. And number one, and Dr. Sharma just brought in one of the questions, that number one biggest myth is, if and when patient asks, I will offer. Why do I have to talk proactively? And that's one of the biggest myths, that it really doesn't happen. The second happens to be, the biggest myth is, I cannot increase my chair time just for the sake of promoting a technology. And we'll talk about this, why this is a myth. The third happens to be, the biggest differentiation. This is very geography based. The biggest differentiating factor that practices try to make and try to communicate to the patients is, they say that, this is such an expensive technology, I'm giving you at a peanut price, posing that to be as a value. That again doesn't work well. And the biggest myth that one has as a practitioner all across is that patients do not pay. They do not have enough money, and do not understand. On that, I want to share a very interesting survey, done in India, not an American survey. That this is very much an Indian survey done with some 18 metros and mini metro towns in India, not long, just 2 years back. Said 6 out of 10 patients in India are willing to pay up to 70,000 rupees for a laser vision correction. Up to 7 out of 10 patients are ready to pay 50,000 rupees for a cataract procedure. And this is the saddest part of it, where only 2 out of the 10 patients are actually offered a premium procedure. So I'm going to share today some very simple ways, with that shocking revelation, simple ways where you can together go back Monday morning and integrate these couple of tips just that I've learned from all of you all to integrate these procedures in your practice. Having said that, the biggest disclaimer is, of course, that good surgical outcomes is absolutely inevitable, and that's no substitute. Considering that to be granted, that there is good surgical outcome which prevails. The first tip that I want to share with you all, which is important, is the self-conviction. And if you're not convinced about the technology, it will never show up in your practice's body language, the verbal, non-verbal interaction that you're making. It'll never show up. And that's why it's important that you get thoroughly convinced about a particular technology. Talk to mentors, visit webinars like this, but you need to be convinced. Otherwise, it's going to become something like, from the place where you wish that, elective procedures would happen to somebody. When you're convinced about a technology, you would come to a situation wherein, and this happens obviously when you're convinced about a technology, that you feel that, every clinically suitable patient must have this particular technology into his or her eyes. So that's point number one. Number two, which comes from the survey that I just mentioned, that 2 out of 10 patients are actually given the options. And Dr. Nishant in his presentation shared very nicely that how, and I visited his practice, and I've actually visited all the practices of all the panelists that are here today. And I've seen Dr. Nishant's practice. Absolutely right. I mean, there's something correct about how patients are told about the advancement or the advent of any new technology for that matter. And that's my point number two. Let your patients know that that there is a technology that is available in your practice. And if you were to crib that there's not enough opportunity, there are several opportunities in your practice. Right from a pre-read material, from the reception to the checkout. There's several ways where this can be very strategically put forward, and this awareness can come in. some examples. What you can do is simple things like posters and standees and so on, several other things. Now, the biggest mistake that happens, and even if you were to design a poster or an education material, or for example, a company provides you, many times you just don't think, practices do not think where to place it. Wherever they see a vacant wall, wahan laga do bhaiya, and that could be next to the washroom. And that's not the correct way. This is such an important science that you need to think and and spend some time understanding where to place these education materials. That's number one. You should be careful about. These days, we all are going digital. Patients are going digital, and simple things, and it's not at all difficult to have QR codes. QR codes today. Google Pay, Phone Pay, and Paytm put together have close to 150 million users every day. And that many amount of people are actually aware of how to scan a QR code and how simple it is to get information from there. And hence, very important is that simple education materials that you have with yourself, you can very easily turn them into a QR code, and have your patients scan this, or the caregiver scan it, and get them tutored while they're waiting. Nobody likes to download an application, in these days for a few hours or for 1 or 2 times. Hence, any web-based application that you have that you can develop, very simply you can develop, is something that you should look forward for. The next one is something which is getting very popular in India as well, and which already is very much existent in many other countries of the Western world, is the culture of sending the pre-read materials. Before they come in, you send them, of course, understood that not many people read them, but the caregivers are anyway doing their homeworks, as Dr. Namrata Sharma just said. Most of the caregivers go and do their Google work. While that is happening, might as well the caregivers might as well go through the pre-read materials. That really helps, when patients walk in and they are a little bit more educated than what it would have been earlier. With that, yet another interesting fact that I want to share. These are the top 3 things that patients does not want to see in a doctor, or dislikes in an interaction. Number one, what they really want to see is the doctors who take his or her own time, to make them feel, give them options. And again, it's just driving them through a fast food joint, saying that A, B, C, D, E, F, G, H. The second happens to a doctor who involves patients in a decision-making process, and that's the point I'm going to talk about. And the third, of course, is on personal discretion. Patients love to have doctors who share the telephone number so that they can be reached out at any point in time. However, what I'm going to share is point number 2 at length, wherein, how can you involve your patients in the decision-making process? And that's where the concept of chair time comes in, and this is something very, very, very important. There is no substitute of your practice chair time when it comes to having any new technologies brought in your practice. It cannot be supplemented by any education material. And that's why you have to be mindful of the fact that this is something that you need to invest freehand. Use tools, use different videos. Just verbal counseling doesn't help. Or simply just scribble around in a piece of paper, show them, and if you want to explain flax, just draw them cataracts, show them the incisions and how the laser beam would let you open the cataract and access to the cataract and make fragments and so on and so forward. Eventually, as Dr. Nishant mentioned in his practice, eventually this you might have to give a larger chair time from your own side, but gradually, the chair time decreases when your staff shoulders the responsibility and they learn, how you're communicating with them. Yet another important thing is the fact that, optometrists are one of the most underutilized assets in a practice, and they can do a wonderful job if they have been made to talk, about. And they come at a very interesting place in the entire patient journey, where that bit of talking about this technology makes a whole lot of difference to the consultant and the counselors all throughout. So that's a culture that one can inculcate in a practice. And last, but the most important part is the concept of recommending. And with our experience, and when we visit a lot of practices, we see that practitioners many times hesitate, most of the times actually hesitate to recommend, thinking that if I were to recommend it would mean that I'm trying to sell a particular process. Well, recommendation is not selling, and this is a skill and art that I've seen with a lot of practices who have been very successful. I've learned this very well. This can be learned as well. I give this example most of the times in most of my talks is the difference between a traditional way of recommending versus a newer way of recommending. You all would have been you all would have come across a situation wherein a patient would say, come to say, you give them the options, and the patient said, doctor, you tell us, what is good for us, which procedure, flax, multifocals, whatever, what is good for us. A traditional way of answering this question would have been, and this is what I see at Mr. Places, would say that, Mr. Patel, whatever you decide, me and my team will do the best. And a recommendation format would sound something like this. Mr. Patel, had I been in your place, for my father, I would have gone for this package. However, whatever you decide, me and my practice will do the best. Now, the patient necessarily won't walk away with a flax and a multifocal procedure, but will walk away with a lot of clarity with the second format of communication. And that's the power of recommendation that you should try. And everybody in your practice, in some form and format, if they're tutored, you should recommend, if you feel if the patient is clinically suitable and it makes sense that, he gets this particular technology. Couple of quick techniques, and I don't call them tricks, which you can use, are these, that we strongly recommend. One happens to be on the left-hand side of the screen that you see is the lifestyle questionnaire. It's a simple format, simple questions that you can make, wherein the patient before the consultation answers about his or her visual needs, what he or she feels would love to do without spectacles, if she or she wanted to get rid of the spectacles after cataract surgery, what are the activities that he or she would want to enjoy, and so on and so forth. It has two benefits. One, of course, you're making the patient think about it, and thinking about it, so that they're better prepared. And secondly, for the counselors and the consultant, it becomes a starting talking point. Say that, Mr. Patel, you just said that you do a lot of computer work, which is your intermediate distance, and you've given an opportunity, you would want to get rid of your spectacles, and so on and so forth. That becomes a very interesting tool. And with this intervention, we have seen that the adoption ratio of any technology is much more higher, especially for the multifocals and toric technologies, much more higher, because there is a two-way interaction that actually happens, and the patient has already said it, that this is what he wants to get rid of. So that's one. And second, there's a very interesting thing, and I wanted to share in this forum, is the toric opt-out form. That's how we call it. Several things to it. Now, if you would have offered, or you or your practice would have offered a toric technology, a toric lens to a patient, which you feel is appropriate, let's say two plus diopters or whatever. And for example, for some reasons, the patient, despite being clinically suitable, despite you feel is affording, denies that, he doesn't want this technology. Then what you do is, you ask them to sign a simple letter. And this is what the letter reads. It says, I, so-and-so, age so-and-so, hereby decide not to opt for the astigmatic correcting IOL. I understand that, by not choosing this lens, I will need to wear my spectacles for the rest of my life, and so and so and so, and you signed it. Here so this is a very simple letter. But when a patient is made to sign this thing, we've seen that the reconsideration ratio is up to 50% high. And they would really consider them, rethink it, because they just have to sign it. And if patients ask you, why do I need to sign this? But what is it all about? And you say that, this is just a normal process that we include, because in our past, we have seen that, when patients, despite we offering these technology to our patients, they've gone to different practice, and they have been offered a toric technology over there, and they come back to us and saying that you never offered us. So this is just to safeguard us, saying that, we have given you the options. Try this out. In any letter format that you can feel, and you will feel that the patients will really start thinking that, here's something that I'm really missing out, and this is something which is close to handicap, say, which I'm letting go, and which could have been cured, which could have been addressed at some point in time. Of course, never to less mention about the patient counseling station. This is one of the most critical part of the entire patient journey. And for the success of any new technology in your practice, this is very important. With lots that can be talked about this, but three things that you can keep in mind: training, tools, and takeaways. This is how we do. Get your counselors trained well, both on the technology so that they understand, and the communication, what should be taught. Second is the tools, in terms of give them a lot of tools. The companies these days help you with a lot of different tools. The fact is that, many times they don't use it, because they're pressed on time, because, they're not forced to use it, or, they just neglect it. These are very interesting, important tools that the patients really understand. Everybody makes a lot of effort in developing these tools, which with your guidance, if they use these tools, simulation applications, models, everything, the caregivers and the patient will only be able to better understand this technology, and we will be able to take an informed decision. And last is the takeaway is the motivation part of it. I think at the initial stage, it's very important that you can consider motivating your counselors by virtue of any form of incentivization, whichever works well in your school of thoughts. It doesn't have to be money necessarily, but whatever works well in your school of thoughts, it's appropriate that you do so that they walk that extra mile in the initial phases. Why it's important? Because caregivers today are the decision makers, and we all know this. They decide the fate of the elective procedure because they did. So hence, a couple of things: do not ignore the caregivers, by virtue of eye contact and talking to them. Do not engage into verbal counseling. Give them tools and resources to share with them, and do not hesitate to recommend. They really look forward for a strong recommendation. What you should be doing, hearing them out completely, as Dr. Namrata Sharma also mentioned earlier that they have done their online homework very thoroughly and they really want to vent out. Good thing is to give them time and listen to them, that this is what it is and this is what they've learned. Give them relevant examples that they understand, and also bring the dependency factor, how with the help of this, your parents, will be less dependent, the dependency factor, and that clicks pretty well when it comes to caregivers. An irritated patient or a patient family will never be in the correct frame of mind to listen to a flax or a multifocal procedure. Hence, the check-in to check-out time experience, the overall patient experience, is very important as well. Now, where there are several things that one can do to improve the patient experience. Here are a couple of quick things that you can probably check over here. Number one happens to be is how swiftly you should have your patients checked in. After the check-in, get into a primary exam in less than 15 minutes. A non-attended waiting period really turns a patient off. Put your primary staff. Primary staff happens to be a front desk, to be much more polite. Let there be adequate seating arrangements. It doesn't have to be very comfortable seating, but there has to be adequate seating. A patient who is waiting for 60 to 90 minutes is definitely not going to be in the correct frame of mind. And have your washrooms cleaned regularly. These are a couple of very tiny things that you can just check box and see how you can enhance and have your patients in a better frame of mind when you're going to have that important conversation. In your practice, in your town, if you have the first mover advantage, let's say the first flax procedure, first image guided cataract surgery, and so on and so forth, hurry up. I mean, this is the best time to do. It's much more simpler. Everything will fall in your advantage. Here is a study here's a study from Harvard, where they said, there was a study done with 672 medical professionals, and out of them, all of them adopted newer technology. 70% of them were successful when they adopted the newer technology. So the chances of adoption of newer technology when you have the first mover advantage is much higher. You can do several things like to promote your technology. Can have your case file, your case file printed with this technology. The website homepage banner can happen. The WhatsApp announcements that you also get a lot of free PRs in your town, and so on and so forth. So if you have that advantage, you might not have that advantage for long. It's time to act right now. The elective procedure multiplication factor happens only when you have developed ambassadors, patient ambassadors in your practice. And that happens when you're able to generate a wow effect in them. All of us does that, but so most of the time the patients are clinically have the wow effect, but they are not emotionally, they don't have the emotional wow effect, which means they know, what probably they feel is this is how everybody sees what's the great deal about it. So they are happy, but they're not super happy to become ambassadors. And that's where, you can do a couple of things, which we call it the post-operative counseling. Spending that additional 5 minutes after the surgery, after the refraction, everything stabilized, and doing a couple of very interesting things, just to get that wow factor. Like, for example, on the left-hand side, you see astigmatism stimulation of a patient who has undergone a toric lens. You can again simulate in the trial set a similar kind of astigmatism that the patient has, and you say that this is what your eyes were earlier. Now remove the trial set, and this is what it is at this point in time. This is what we've done with this new technology. Or the one that you see on the right-hand side, which you can do with almost every patient, is the pre-op reading evaluation sheet. This is a simple paper, simple sheet, which has different sentences in different font size. Before the surgery, you make them, make them read the patient a particular font, and then they take a signature of it. And after the surgery, when you see the refraction is stabilized and so on and so forth, make them see, and they will see, make them read, and they will read an additional line, and they've already signed. And then you say that this is what we've done. We have reached from here to here. These are tiny things that you do. They become very happy, and they then become your ambassadors, and they go out jumping from the chair and say that you must get yourself done. You must get your surgeries done here. You must get this particular procedure done. When it comes to pricing, I think more than the price, it's the complexity of the fee structure that really turns a patient off. So try to make your pricing menu much more simple. Simple things that divide your surgery types into whatever formats that you have: a standard, flax, 3D, whatever. And then your lens types into very simple format of standard and lifestyle lenses. In lifestyle, you could have a toric and PCL, and so on and so forth. Let the patient choose from whatever, from a mix and match. You keep your fee strict. This is what it is for this lenses. And you can choose. You can use a standard lens with the toric or a flax with this. This becomes much more simpler. And these days, also it also makes merit that a lot of practices I've seen and we recommend that they've started charging about advanced diagnostics, a small premium to it, and patients have been paying very well when they've been explaining the value that is attached to it. This is almost my last slide. This is on the insurance corner. We all know that culturally, none of us want to pay beyond the sum insured amount, and that's why it is critically important for the success of the elective procedure, the premium procedure, that the insurance desk or the insurance person who is managing insurance is also well capable of handling the situation. That's why you should not only have a lot of information and knowledge about the insurance, but also you should also be made aware of the technology, what it is all about, and then certainly being able to quote the value and the opportunity of the copay option that most of the companies today offer. That's something that can kill that particular barrier and could sail through pretty well. But last but not the least, I think just like anybody else, one should do your homework. Take up 1 month every month, just spend a couple of hours just studying your practice. Total cataract procedures that you've done, the elective procedures, what were the dropout reasons, and so on and so forth. This homework is absolutely essential for you to propel even more stronger, and you'll come out. You'll really get some very fascinating facts as you move forward and you do this study every month. So finally, if I were to summarize, I think 3 things that I would say, as a mantra from our experience for having premium procedures in your practice. Number 1, inform completely, recommend wholeheartedly, and leave willingly for the patients to decide, and for them to decide any of the elective procedures they want to for themselves, and you'll see a lot of good success in your practice. So finally, all these years, all of you practitioners have been busy giving time in your practice. This COVID time has actually facilitated to think and give some time on the practice. So please do think about it and see how well you can integrate and have your premium procedures more seamlessly integrated in your practice. You can also reach out to any one of us, and we'll be happy to guide you with any help that we can. Thank you so much for your time.
So, Saurabh, thank you so much. I think we'll have to import you from out of Alcon into AIOS to give longer courses, on how to manage practice, because these are the things which we actually do not know. We know surgeries, we know, we read from books, we read from journals, we watch surgeries on YouTube, we see experts doing it. But these are the kind of things which ophthalmologists are bad at, and these are managerial tips and tricks. These are things to increase your business acumen, to increase your practice, if I may say so. And this
Yes.
is something which we all are universally poor at, and the things that you told us made a lot of sense, and you correlated with each one of our opinions and talks. That was the best part. So we felt like we were integrated into the whole talk. Was actually prepared much before our own comments here and our own talks here. So thank you
Thank
so
you so
much
much.
for that. If there are any questions from the panelists to Saurabh, take them. I think he summarized it very well. to copay, to audit. More importantly, I think it is also important to have meetings with the insurance people to tell them, how technology is moved fast,
Correct.
especially the IRDAs and others, and tell them that, rather than why should the patient be paying any amount on it if
Absolutely.
technology,
Absolutely.
then they should be bearing the cost. That is something
Absolutely.
which takes years to happen and sometimes does not happen at all.
Right.
So, if
Right.
there are any questions, Dr. Gopal Raju, Dr. Saurabh, or Shant?
Yeah, if we can arrange with the insurance people about the concept of the copay. So majority of the insurance people
Yeah, so
yeah, copay, and then from the AIOS side or from the industry side, if they can coordinate with the insurance.
I think it has to be a collective and a cumulative effort by all stakeholders or partners or people in question. Only then it can happen. And if a single ophthalmologist or if a group of ophthalmologists goes, it's not going to happen. So it has to be collectively. The industry has to help us in that. Plus the ophthalmologists whose stake are there, and the patients also for that matter. Even the public
Correct.
has to be taught. That is very important. Public should know that it is for their good, and the patients have to be educated that it is for their good, and they also should be someone who should be asking for it. So I think we've had a great webinar today. Congratulatory notes from all over Facebook, YouTube, and Zoom platform also, which we have, and there are great numbers today. We had a good amount of attendance. The figures will come in, and I will email the figures and WhatsApp the figures to all of you. So, if there are no questions, there was just this question which was there, and it is because we've not compared, but Dr. Leela Mohan wanted to know, we've touched upon it before. Are there any issues with the Indian hydrophobic IOLs? So, I think there are no issues as such, but only thing is we've not compared them with there are not enough studies or enough data, or maybe we have that data, but not enough analysis done to compare them and to say, how well they fare, or how superior they are, or are they equivalent. So, with this, if there are no questions, any one last comment from each of the panelists? Nishant?
Wonderful session. We have all been enlightened more than what we knew before the start of the session, and probably I would be looking into the 3D part now more convincingly after seeing the surgical part, and already have ordered the hybrid tip. That's what I can say.
So, Saurabh?
Yeah, so it's been a great session, and I've come to know a lot through Saurav as well. So it's always a pleasure hearing him, and I've been listening to his talks for the past couple of years. And each time you hear him, you catch new data and you try to do something differently.
Uh, uh, Dr. Gopal Raju?
Yeah, I think we should congratulate you for nicely moderating and then bringing out best out of us. And then the next thing is, see, if you see Namrata, what I feel is, if we see our percentage of the multifocal and then the lifestyle IOLs, even though we are very much convinced about the technology, but our numbers are still in a single digit or maybe around 10 to 20%, not even 20%.
Yeah.
I think once that number of the percentage increases, then it speaks of the technology and then the acceptance. I don't know, since long time we were trying to increase that percentage. Maybe what I see is only the cost barrier. Except the cost barrier, we could overcome the technology aspects and then the other surgical aspects. I think our challenge is to increase that number. Thank you.
Yeah, I think that's very well said, Dr. Gopal Raju, that from the time that these premium IOLs and this practice is available, we are stuck at 15 to 20%. So I think that is something, which we need to increase, because uh, this is not like, say, wavefront guided LASIK, which is only suitable for 10 to 15% of the LASIK patients and not for the rest. This is something which is there for all, and our patients also need to upgrade. So I think we need to counsel them properly and should try to get the numbers to at a higher level. So with this, I think we will come to the end of the webinar. If there are any questions and if anybody wants to ask, you can still email to us and we will post them to our experts for them to answer those questions. So thank you very much. I would like to thank all our esteemed speakers, Dr. Gopal Raju, Dr. Nishant Patel, Dr. Saurabh Chaudhary, and of course, Saurabh Das for your very enlightening talk on practice management. We
Thank
would
you very
like
much.
our audiovisual team, Mr. Sunil, Mr. Kripal Rana, and also Alcon team for having sponsored this and for having had this entire discussion and webinar. And we hope for more educational webinars in future as well. So thank you very much and see you again.
Thank you. Thank you.
Thank you. Thank you all. Bye.